Yeah. So this is week 11 we're going to be running through today. We're running through the physiology of arteries and arterioles, particularly how they react to the cardiovascular system. We're also going to be running through microcirculation, which is related to lymphatics, Pharm, vasodilators, and HEP improving performance. So Andrew has done the slides on microcirculation I'll be presenting. Katja's done the pharmacology, vasodilator slides, and I'm not sure who's done HEP, but we'll figure that out. So to start off, we're going to start off with arterial blood pressure. So in clinical skills, you might have had experience. Just so I have an idea, have you done blood pressure? Have you learned that yet? How to take someone's blood pressure? Yep. Okay, wonderful. So this is going to just be showing us why that works. So there's a problem when we think about what we learned last week, which is that blood is ejected into the aorta during systole. And the problem with that is that the flow of the heart is pulsatile, but it'll be very unstable for the tissues and organs of the heart if their supply is only pulsatile or fluctuates. So there has to be some sort of mechanism that ensures blood flows through the tissue and organs continuously. So any ideas of what that could be? So it's maybe not something you've thought about before. The answer is that arteries act as elastic tubes. So arteries, so the problem was just the person's joined. I'll just show you what we're talking about. The problem is we said that the ejection of blood through the heart is pulsatile and it's ejected through systole, but there needs to be a continuous perfusion of the organs and tissues. And the way that's done is through the mechanism of arteries that act as elastic tubes. So that means even during diastole, when the heart is filling, there is still blood that can be pumped out. And it also allows these arteries to act as pressure reservoirs. All a pressure reservoir is it means it has a high amount of pressure in that area, and that can transport to a low pressure area in order to perfuse the tissues and organs. So I'll show you an image of that just over here. So here you can see during systole, you have all of this blood being ejected through. But what's interesting is only a third of it is actually supplying the vessels, the organs, the tissues during systole. The other 2/3 is going into stretch the walls of the vessel and are stored in kind of this plane over here. Then during diastole, you have elastic recoil, which is like a spring contracts, and those 2/3 are then further contracted and spread throughout the heart. So that way you have constant perfusion of blood to the tissues and organs of the body. So another relevant factor to the system is that arteries have large diameters. So if you remember from our previous lecture, we discussed resistance, and resistance is an impedance to flow, and it does so to the factor of 4. So a small diameter is the greatest factor that can contribute to resistance to flow. So when our arteries have large diameters, that means they allow conductance of blood to various organs of the body with a very reduced resistance. So those are our two main mechanisms for supplying blood to the organs and tissues of the body. Now we're going to talk about kind of more theoretical concepts, which is something called systolic blood pressure. And systolic blood pressure is the pressure of your blood vessels during systole, when blood is ejected through the aorta. Diastolic is the pressure in the vascular system during diastole, which is made from those 2/3 of blood compressing and that elastic compression. Hey, Andrew. And pulse pressure is just the difference between these, the difference between the systolic and diastolic pressure. Now, pulse pressure is primarily theoretical, and the only reason you really use it is to figure out mean arterial pressure, which is just your diastolic blood pressure plus 1/3 of your pulse pressure. So in clin skills, this might look familiar to you when you took some blood pressure, and this is now we're going to actually be discussing why that really works. So when you have a really, really high, you've pumped the cuff to as much as it can, there's a lot of tension on the blood vessel. The blood vessel is not patent. The pressure has compressed the blood vessel closed, so there's no blood flowing through. Then slowly you're going to let air out, and eventually the cuff pressure will be just below systolic pressure. And that's when you hear your first sounds. So the reason why that's working is that the systolic pressure is now enough pushing against the vessels of the vasculature to oppose the pressure being composed by that mechanism, that what's called the compression pack. And that means a little bit of blood can flow through, but it's very turbulent because it's just a tiny bit opened. And you'll hear your little pumping sounds like that. Now, as this pressure of the cuff gets smaller and the vessels can dilate wider due to their internal blood pressure, the tapping will get louder and the sounds will become louder, but it will still be turbulent because it's not completely patent. That will continue until finally the cuff pressure will be below. I can never hear my brachial artery normally. I can never hear my brachial artery normally. Will we only be able to hear it if we apply the pressure from the cuff? I think you can usually hear your brachial artery normally. It's just tough. But yeah, you can. Okay, Rip, yeah. I couldn't feel my brachial pulse. It took me forever. But yeah, you can. If you need to use a cuff, then you use a cuff. So when the cuff pressure is below diastolic pressure, then the vessel is always open. So that means the vessel is completely patent and there's laminar flow through and you'll have no sounds. The sounds are called Korotkoff sounds, Korotkoff sounds. So now blood pressure, just very briefly, there's one slide on this, is your blood pressure is a really good indicator of disease and it represents quite significant risk factors, particularly hypertension. So hypertension is a very large risk factor for cardiovascular disease. If your blood pressure is clinically greater than about 140 on 90, then that's like considered very suspected hypertension and considered high blood pressure. Quite serious. 130 to 139 is also like hypertension, but it's less so. This is quite significant. And that means that usually what's required is you need to wear a blood pressure monitor for 24 hours and that records blood pressure at fixed intervals. So a really important point is you don't diagnose hypertension on one measurement. The diagnosis of hypertension or hypertension or hypotension has to be over a significant period of time and it's graphed and then analyzed. Another important factor is there's something called white coat hypertension, which is when people in the clinical scenario, their blood pressure tends to be quite higher than what it normally is. And that has to be considered as a factor, which is one of the reasons why we don't just take one-off read-ins to diagnose these. If the blood pressure in the clinical encounter though is very sufficiently high, you can consider starting medication, but you don't really need to know that. All you need to know is normal blood pressure is about 120 to 180. Anything above that is elevated. Hypertension is about 140 on 90. For stage 2, quite serious. Stage 1, about 130, 139 to 80 on 89. It does change depending on where you look. So just know about the value. No 120 on 80 is normal. Anything above that is high. Similarly, hypotension is generally considered less than 90 on 60. Again, it depends where you look. And hypertension was very recently changed in terms of classifications, which is why you'll have further conflicting information. So just have a general idea of that. So again, consistency is key. Consistent above or below a threshold is what determines hypertension or hypotension over 24 hours or elongated period of time. Next, we're going to talk about cardiac output and metabolic demand. And the reason why we're going to talk about these is to show you that cardiac output isn't fixed and the places in which blood flows to the tissues isn't fixed either. So the blood can sometimes, in a state of heavy exercise, for example, your cardiac output will increase because you have increased metabolic demand and you further could have increased sympathetic activation globally, which can lead to greater heart rate, greater contractility, for example. And so most of your blood is going to recirculate to your muscles where there's a higher metabolic demand. And that's going to be in a greater proportion to normal. So not only is the cardiac output increasing or the amount of blood ejected from the left ventricle to the aorta increasing, the distribution is also changing depending. And so the question we've got to ask is, how does the blood know where to go? And the reason for that is because of arterioles. So you could have learned about arterioles in histology before and kind of rolled your eyes and not really care, but arterioles are quite important physiologically as they control the proportional distribution of blood flow to the organs and tissues. And the mechanism they do this through is through altering resistance. So if you remember, if you have really high resistance, you're going to have decreased flow, which means if arterioles contract, they're going to limit the amount of blood going to these supplies. So for example, here, during heavy exercise, let's talk about your gut. During heavy exercise, the arterioles to your gut are going to constrict. You're going to have reduced flow and a less proportion flowing to your gut. whereas at resting state, they're going to be more dilated, and so a greater proportional flow. It doesn't really help us though, because how do they know when to contract? And the reason they know when to contract are through two systems. One is local and one is global. And we're going to begin by discussing local, which is through autoregulation. And there are two principal autoregulation mechanisms. One is the metabolic control, and one is a myogenic mechanism. If you can remember all the way back to when we were discussing coagulation, there's a similar sort of thing going on, but I'll discuss that a bit later. So in metabolic control, the triggers are really increased metabolic activity. So increased CO2, which is a waste product, decreased O2, which is what's being provided to the cells for that ATP production, and increased H+ or acidosis. And in response to these, you can think of them as autocoid factors. There's going to be dilation of arterioles due to relaxation of smooth muscle. And so that means these tissues are going to be supplied. So in exercise, when your muscles are producing lots of CO2 and lots of hydrogen ions, the arterioles will dilate and they'll have increased supply. And this is especially important in skeletal and cardiac muscles, but does occur in all tissues. The myogenic mechanism is also known as a stretch response. And this is really important as it allows organs to maintain constant blood flow during fluctuating arterial pressure. So if you think about your daily life, if you're running, you're going to have a lot more cardiac output than if you're like resting, like we saw before. But you want to maintain like a consistent flow of blood to your body and to your kidneys, and this is primarily for kidneys, but you want it, it's present everywhere. You don't want your vessels or the blood supply to fluctuate on everyday, daily to day things. So this is a protective mechanism to make sure blood flow is consistent. Again, this is really most important in the kidneys, which you haven't learned about, but it is something to keep an eye out for. Local refers to metabolic and myogenic mechanisms that are controlled by arterioles and regulate on an individual level. Global systems are regulated by whole body coordinated regulation, such as sympathetic and hormonal. So these are the reflex control of arterioles. And most arterioles have sympathetic supply, but they have limited parasympathetic supply. There is one exception to where arterioles have parasympathetic supply as well. Does anybody know where that is? Yeah, good job. Genitals, yeah, so we got penis and genitals, those are both correct. So the parasympathetic supply to the genitals, so to the penis, will maintain erection, and to the clitoris will maintain erection. So very good, very impressed you knew that. Sympathetics on a nerve terminal will often release noradrenaline, which will act on adrenoreceptors or alpha receptors, and this will lead to smooth muscle contraction. So because the smooth muscle is contraction, there is increased resistance, so decreased blood flow. So if you can think about it, increased sympathetic activity to alpha receptors will constrict and decrease blood flow. Decreased activation of alpha receptors will lead to dilation and increased blood flow. Just a side note on the difference between alpha receptors and beta receptors. There's definitely more differences to what I've described, but this is how I remember it. And this will be particularly important when we discuss beta blockers later on. Alpha-1 receptors really affect peripheral resistance, which is how I think about it. They affect the constriction. They stimulate the constriction of arterioles. And so therefore, if you have your arterioles constricted, you have a lot of pressure for your heart to overcome when pumping blood throughout. And therefore, alpha-1 mediates blood pressure and peripheral resistance. On the other hand, beta-1 affects heart rate. So really important concept for you to understand. So if we go back here, during our heavy exercise and sympathetic response, we have the alpha-1 receptors in our vasculature contracting, limiting perfusion of the gut. Whereas in our resting or parasympathetic response, our arterioles are dilating and so adequately perfusing the gut. For example, hormones work as well. Adrenaline is a hormone. While adrenaline and noradrenaline are both catecholamines, I'm referring to noradrenaline emitted through nerve terminals, whereas here I'm referring to adrenaline secreted by the adrenal gland as a hormone. Adrenaline can act on alpha receptors or beta receptors. Alpha receptors will cause a constriction. Beta receptors will cause a dilation. So that's why a good question you might have had is, well, okay, I understand what you're saying, that in the gut, if you have a sympathetic response, the arterioles are going to constrict, and you're going to limit it. But when you're heavy exercising, you have a substantial sympathetic response as well. So why is there increased blood supply to the muscles? And the answer to that is due to the receptor difference. So your blood supply to your vasculature is often alpha receptors, and those will contract, whereas to your skeletal muscles, you'll have a significant amount of beta receptors, which will lead to dilation when stimulated. I thought that hormones would take a long time to work, so why are they used to alter things if we need changes quickly? So it's a good question. What we're talking about is, you're completely right. So you have a pituitary gland, and some hormones synthesized there take a lot of time to be synthesized. But your body also has a capacity to store hormones. And it's usually the storage of hormones that are being triggered, not the synthesis of hormones, which take a long time to synthesize. So your adrenal gland is going to be filled with a storage of adrenaline that will be stimulated by sympathetic fiber and then released in the circulation. Likewise, you don't know what the thyroid is yet, probably, but there's other hormones that are stored for, like thyroid hormones, for example, are synthesized on the spot, but they're stored for 3 months, but they take a really long time to synthesize. And the reason why they're stored is because they take a long time to synthesize. So it's a great question. Did I say the question? That would have been helpful. I thought hormones would take a long time to work, so why are they used to alter things if we need changes quickly? The answer is because they're stored. So Andrew, I believe you're with us.
Hello guys, been a while. So I'll just be taking you through some microcirculation. It's not too bad. It's fairly intuitive. So I think we'll go to the next slide then. So microcirculation is basically just referring to your blood flow from arterioles to venules, and that's just going through your capillaries. And as you probably already know, that's where you get your like swapping of essential nutrients, and you're moving your waste products. So at rest, most of the capillaries are closed, and instead the blood travels through something called meta-arterioles and the thoroughfare channels. I would have put an image, but I actually forgotten. So let me see if I can find that right now, actually. I should have it in just a second.
Do you want me to stop sharing, or are you going to post it on
Yeah, I'll just I'll get it up in a second.
Awesome. Just let me know.
Oh, sorry, David, I need screen sharing. Yeah, also muted.
So I said, what I'm going to do is I'm going to stop sharing, and then I'll make you co-host. There you go.
Thank you. So this is what I was referring to. So this is the meta-arterial. It's sort of like a more central arterial, so to speak, and this is your thoroughfare channel, which is like the venule equivalent. So at rest, normally these capillaries are closed. The smooth muscles that constrict and prevent blood flow through the capillaries, and instead they sort of just travel more directly. But for example, if you're doing something like exercise, then you need blood flow because your tissues need more blood supply, and that's when you'll get your capillaries opening up and more blood flow through, and you'll have more exchange. Okay, all right. Do you mind sharing again, David? Thanks.
No worries. Let's figure this out. Here we go.
Thanks. And something else to note is that in your microcirculation, basically where your capillaries are, you'll have a lot lower blood pressure. When you're entering it, it's about 40, and when you're leaving it, it's only about 20. And this is because obviously your capillaries are a lot more delicate, they're very small vessels, so you don't want to rupture them with high blood pressure. Next, please. Okay, substance exchange, not the most important thing in my opinion, but just vaguely know them and I think you'll be fine. So filtration is when you get movement of fluid from plasma to interstitial fluid, and absorption is just the opposite. So it's when you get movement from interstitial fluid to the plasma. So there's several ways this can happen. The first thing is just through direct diffusion. Let me see if I can annotate. So that's referring to this pathway. And that's where you have something that's lipid soluble. So gases like oxygen or CO2 can just directly diffuse through the endothelial cells of the capillaries. And you also have little pores between your cells. And so you can also have diffusion through these pores, which are called intercellular clefts. Not the most important thing to know, but yeah. And this would be for something that's lipid insoluble, so something like glucose, ions, amino acids that are polar and can't go through your cells. And what you can also have is something called bulk flow, which is this one. And that's just the flow of water and dissolved substances. So that differs to something like the second one, the diffusion through pores, which is just diffusion of the molecules itself. But bulk flow refers to both the flow of water and the dissolved substances within it. And finally, you have something called vesicular transport, which is just using vesicles. And that's for large molecules, so some hormones, for example. And with diffusion, there's two major forces that you should know. So one is hydrostatic pressure, which is basically your blood pressure. And so this drives filtration. It will drive movement of fluid from the capillaries into the interstitial fluid. Something that opposes the major force that opposes it is called plasma osmotic or colloidal oncotic pressure. So you'll have plasma proteins in your capillaries, right? And because they're too large to diffuse, they'll stay within your capillaries. And because they're staying there, they're sort of just generating concentration gradient. And that will oppose hydrostatic pressure, basically. So if you have a look at the diagram, you can see that when the blood is first coming in, the net filtration pressure is sort of greater on the hydrostatic pressure side. So you'll end up getting fluid going out of the capillaries. In sort of the middle at some point, the hydrostatic pressure and the colloidal osmotic pressure will sort of balance each other out because your blood pressure is decreasing. If you remember, I said before, when you're starting at the capillary. And so when you get to the end, your plasma hydrostatic pressure will actually be lower than your colloidal osmotic pressure from your plasma proteins. And instead, you'll actually get some resorption. So you actually get some fluid moving in from the interstitial fluid into the capillaries instead. Just a quick note on lymphatics, because I think it gets mentioned in the lecture, but don't need to know too much about it. So every day, you'll get some net filtration of fluid from your plasma into the interstitial fluid. So you might be wondering, where does that go? So some is reabsorbed by the reabsorption at the end, but this is net filtration. So you still have like that excessive amount of fluid. So this is taken up by your lymphatics. So they're kind of almost like a entire other transport system for fluid. And they'll all sort of converge, and in the end, they'll empty into the subclavian vein. And if you don't empty this interstitial fluid via lymphatics, you get something called edema, which is like the accumulation of fluid in your interstitial space. So these can be due to a couple of reasons. So if you have increased hydrostatic pressure, like hypertension, you can imagine that you'll drive more net filtration. And if you have decreased osmotic pressure, for example, if you somehow lose your plasma proteins as you can in renal diseases, then you won't get as much reabsorption. If you get lymphatic drainage blockage, then obviously there's nothing to drain all that fluid. And you can also have increased permeability. So something like inflammation, where you have histamines and all of that make it more easy for the fluid to flow outwards from the capillaries. Next, please. Yeah. Okay, so a little bit more about veins. Veins are sort of the volume reservoir. They actually contain about 60% of your blood volume. It's low pressure. They have a large diameter and low resistance. They also have thin walls. So if you've seen any of the histology images, you might know they have few smooth muscles and they have compliant walls. So that just basically means they're sort of soft and not very rigid. And veins will also have one-way valves. So to ensure that you don't get backwards flow. Venous return refers to how much blood is flowing back to your heart, and there's a couple of factors here. So there is the pressure gradient between the veins and the right atrium. So if you imagine the pressure gradient is large, then obviously you'll get more blood flow return to your right atrium. If the pressure gradient isn't very big, then you won't get as much return. There's also the skeletal muscle pump. So basically when you move your muscles, they'll contract and they'll sort of constrict the veins, I guess, and they'll sort of push blood through your veins. And because you have these valves, that stops the backwards flow and they'll just keep going forward instead. And you also have your respiratory pump. So if you breathe in through inspiration, your thoracic pressure will decrease and your abdominal pressure will increase if you're just thinking about how the diaphragm's moving. And this essentially increases the pressure gradient from your veins to your right atrium, and that will also increase venous return. So venous return is important for cardiac output and stroke volume. And if you think about it intuitively, if you have more venous blood returning to your heart, you will get a better cardiac output. Yeah, next, please. So this is probably the most important part of microcirculation. I think if you're going to take anything away, it should be orthostatic hypertension. So this is basically hypotension when you stand up from when you're sitting. And normally your body is pretty good at adjusting. It comes back to normal within a few seconds. But for some people, this doesn't happen. And orthostatic hypotension is defined as a systolic blood pressure drop of 20 or more, and a diastolic blood pressure drop of 10 or more. So the cause is basically when you're sitting down, gravity is causing the pooling of blood in your legs, and you're not really getting much venous return or cardiac output. And so when you suddenly stand up, all of this blood is still in your legs. And if you think about when you're standing up, sort of almost like the inertia of the blood, the blood will sort of stay, will not want to move, I guess, while the rest of your body is moving upwards from a physics standpoint, if that sort of helps. But basically, if you're not getting as much venous return, and because you have less venous return, you have decreased cardiac output, that will decrease your blood pressure. And if you have really, really low blood pressure, then yeah, you can faint as well. So that's like the dizzy sensation you might get sometimes when you suddenly stand up. And yeah.
Sorry, just a question. Someone's asked, how would you measure the drop if it occurs in a few seconds?
I'm not sure, to be honest. I suppose you wouldn't be able to do it by the normal cuff. I just have. Oh, I think they do talk about it in clin skills. Do you remember?
Yeah. So I think Andrew's really right. So I'm not exactly, within a few seconds isn't like 1 second. It's like you can clinically measure someone's blood pressure when they sit down. Then when they stand up, when you measure their blood pressure again, you can see a significant difference. So I don't know exactly how many seconds is, but it's definitely clinically different. So it's definitely possible.
Okay, there you go. Okay, shall we move on? So normally how your body returns to normal is something called the bioreceptor reflex. So you might have heard of bioreceptors, but they're basically stretch sensitive receptors in your aortic arch and your carotid sinuses, and they can sense your blood pressure through how much your arteries are stretching, basically, hence stretch sensitive. So if you have low blood pressure, they usually just fire at like a fixed rate, but if you have decreased blood pressure, then you'll have decreased firing from your bioreceptors, and they'll send afferent information, so information into your brainstem, like the cardiovascular center. And as a result of that, your body adjusts and you increase your heart rate. So you do that through vagal withdrawal. So your sinoatrial node in your heart will get reduced parasympathetic influence, basically, and you'll also increase sympathetic activation of the sinoatrial node, and that just make your heart beat more quickly and stronger. And you also get increased sympathetic action on your on all of your vessels, basically, so on your veins and arterioles. And when they constrict, you'll end up getting increased blood pressure. And that's basically microcirculation. So I think the most important thing is just a general understanding, and then, if anything, just the orthostatic hypertension and bioreceptor reflex. But you'll hear much more about orthostatic hypertension. It'll come up a few times in the future. Yeah, that's it.
Yeah, and just with that, I can be even like up to 2 minutes. There can still be a difference. So it can be quite a bit of time. I'll just highlight a couple of things Andrew's mentioned are quite important that aren't really explicitly said. But last year, a third year told us we were supposed to know what this was. So I'll just mention it to you. You can see here how if you have a lot of protein in this blood, it's going to have an increased osmolality, and that means blood is going to come into the vasculature, into these vessels. Now, what happens is you can have a loss of protein, particularly due to damage to the liver. And that means the concentration of solutes in the solvent of this blood decrease. And because there are more solutes there than solutes here, the water will flow out. And that flowing out of water builds as something called ascites. So ascites often occurs due to a loss of protein. And as Andrew mentioned, there's less resorption because this has a lower osmolality. Yeah. And Andrew also mentioned the skeletal muscle pumps. These are an important function of the fascia in the lower limb, which I don't know if they've told you that, but that's something that is quite examinable. The fascia exists so when these muscles contract, the veins are compressed and they can be plumped up. But yeah, Andrew, that was really great. I think I learned a lot too. So Andrew might need to help me with this because Katja has made these slides and she's asked us to go through them. So,
sure, we'll try our best then. Yeah.
It's only all of pharmacology for cardiac. So is this why some people with supraventricular tachycardia rub their neck and this helps? I have absolutely no idea.
I haven't heard of the ILA, but that's an interesting thought.
Yeah. The only valuable information response I can give to that is an important thing, and what we're going to discuss shortly, is if you have hypotension, so low blood pressure, in order for the heart to maintain cardiac output and perfusion to tissues and organs, your body is going to often go into tachycardia. Because if you can remember, cardiac output is stroke volume, which is how much blood is ejected. If your blood pressure is low, then that will be decreased times your heart rate. So often your heart rate will increase to compensate. So, I mean, it makes sense that if you increase your venous return, your heart rate will decrease. Any thoughts, Andrew?
Yeah, I mean, I'm not too sure, but I think that's probably something to ask clinical skills tutors, probably.
Yeah, it's a good question. Good that you know that.
It is a good question.
So Katja likes doing these learning objectives, which are great. So we're going to talk about the symptoms and causes of angina. There are a lot of different types of angina, and it's incredibly clinically relevant. We're going to talk about the drug classes used in the treatment of angina, their mechanism of action, adverse effects, and finally on nitrates. So this is quite an important lecture for your whole career as doctors, actually. So we're going to talk about symptoms and causes of angina. So angina is an occlusion of a vessel. It's not a full occlusion, but it's often a partial occlusion of the vessel. And you have two types of angina. One type of angina is called stable angina, and that's often through an atherosclerosis buildup of plaque. And that's going to partially occlude the vessel of your coronary arteries. And at rest, you're not going to notice it. because the blood can still flow through. But when you exercise and you really exert yourself, we saw how our cardiac output goes up, our oxygen demand will increase. And so you're going to start to feel severe crushing substernal pain that can radiate while you're exercising. So pain on exertion is known as a cause of stable angina. You often have shortness of breath that lasts a few minutes, and female patients may present with nausea, vomiting, back and jaw pain, which is quite reflective of an AMI. So always a differential for angina is an AMI, differential for an AMI is angina. Good differentials to have at the back of your head if you're ever asked. Cause is basically reduced oxygen to heart muscles due to the coronary arteries. Coronary vasospasm, okay, interesting. So she's put in a third type of angina that you don't really need to know. So I'll talk about the second type. The second type of angina is something called unstable angina. Unstable angina occurs when there's thrombosis, so when clotting of the vessel, and that quite severely occludes the vessel. There's still enough so you're not having an AMI, there's not infarction, but you can also get the pain at rest as well as on exertion. The final type of angina is a vasospasm or a coronary spasm of the arteries, coronary arteries, and that also limits the blood supply to the heart, and you're often given nitrates for that. I don't know as much about that as the other two. The other two are definitely very important, but these are all very good differentials to pop out during your monskis that you're going to have. So angina occurs when the demand of the heart muscle exceeds its supply. And so you can think, in order to treat it, we're going to try and decrease the demands of the heart muscle. And the way we're going to try and decrease the demands is decrease the contraction, so less oxygen is required. We're also going to try to dilate the coronary arteries to increase supply. So those are our methods that we're going to approach this with. Stable angina can become unstable angina, which is important to know. And it's often chest pain for more than a few minutes.
I just add something quickly. If I remember what I was going to say. Yeah, so angina is like the pain is basically because your myocardium, your heart muscles are dying because they're not getting enough oxygen. And this is like, angina can be like a whole spectrum. So you can have like really mild angina all the way to really bad angina. So atherosclerosis as well, where you're getting like fatty buildup in your arteries, that can be sort of a spectrum as well. You might have atherosclerosis that's not so bad. And so your angina might not be so bad. You might only get it when you're doing really intense exercise. But if your atherosclerosis is, at a much later stage and it's occluding a significant part of the vessel, then that's where you might start getting really bad angina. And even if you're just moving a little bit or walking a little bit, walking up the stairs, then you can get like really bad angina from that. And you don't even have to have a rupture. You don't really necessarily have to have a full clot. You can still get unstable angina if the atherosclerosis is really bad, or you have, it's just some sort of problem getting blood supply to your heart.
Yeah, that's a great point. And often a clinical question you'll hear is, do you feel any chest pain, any shortness of breath when you walk up or down the stairs? And that's often screening for angina. So chronic stable angina there's showing a lot of evidence that there's atherosclerosis, and often you'll do stress tests. I think House does it a lot. I don't watch House, but I think I've seen something on that, where you make the patient do exercise to see if that induces some pain and angina-like symptoms. Unstable angina is showing some evidence of atherosclerosis, but often is involved with acute coronary syndrome, and there could be thrombi formation formed. Variant of vasospastic angina, there's no atherosclerosis, and it's due to spasm of the coronary arteries. You're going to want to use calcium blockers. So some calcium blockers are selected for the heart, some are selected for the vessels, some are for both. You're going to want to use a calcium blocker that we'll discuss in a bit, like amlodipine, which inhibits calcium in the blood vessels, which means there's less of a contraction, so less of spasm, and you're going to have nitrates to dilate the vessel. Why does unstable angina have less evidence of atherosclerosis than stable angina? Andrew, do you want to go? Do you have any idea?
Yeah, so I think the point here is that if you have chronic stable angina, like you get it every single time that you're doing exercise, and that's suggesting you sort of have you have a partial occlusion, because like when you're at rest, that partial occlusion is enough to get enough blood flow to your heart. But once you start doing exercise, then every single time you get you get angina, and that's chronic and stable because that partial occlusion means you don't get enough blood when you're exercising. I think unstable angina, what Katja was maybe getting at, that it's some evidence of atherosclerosis, is that perhaps unstable angina could also be due to something like a blood clot formation, rather purely atherosclerosis. Because you could still get unstable angina if you have bad atherosclerosis and your heart's just done. It's just been too long with not enough oxygen, and so like the heart's going into a worse state and it's becoming unstable. But it could also be because that you get just a thrombus forming, and that's just completely blocking a vessel. So I think that might be what it means, that it could be atherosclerosis, or it could just be an unpredictable blood clot. I think that would be my guess.
Yeah, I did just search it up, and the answer is that nobody knows. But I think when Katja wrote this as well, I would have interpreted it the same way as Andrew. When I think of unstable angina, I think of a thrombosis formation, which isn't always the case, but yeah, that's how I would differentiate them. But it's a good question. What's the difference between unstable angina and AMI? Unstable angina doesn't completely occlude the vessel, whereas an AMI is a complete occlusion, complete infarction. There's no blood supply. Whereas unstable angina, it's mostly occluded. So my image buzzword of unstable angina is a thrombosis that is blocking most of the vessel, whereas an AMI is a thrombosis that is blocking the vessel.
I'd perhaps think of it almost sort of like a precursor to a heart attack or myocardial infarction. So if you have unstable angina and you don't treat it, then perhaps that will progress into a myocardial infarction. So it's just sort of not quite there yet, I guess.
Which is a good point about all of these are all a spectrum. So often chronic stable angina will become unstable angina, and unstable angina can become AMI. Yeah, and they're also associated with these vasospastic anginas, but I just don't know enough about them to comment too much on it. So risk factors, this one we can do. Risk factors for angina are your common cardiovascular risk factors, your hypertension, cholesterol, and smoking. Remember, a lot of this atherosclerosis buildup is an inflammatory process, so lots of inflammatory mediators can be risk factors as well. Angina can be precipitated by exertion, cold, stress, large meals. This is the most important part, which probably should have asked you this as a multiple choice question, but it's okay. The three main classes of drugs to treat angina, this is very important, quite examinable, are nitrates, which increase vasodilation, calcium channel antagonists, which decrease vasoconstriction, and beta-1 adrenal antagonists that stop or limit noradrenaline in the heart. Let's go through these one by one. Nitro or nitrates increase vasodilation. They do this both of the coronary arteries, which means there's an increased supply of blood to the myocardium. They also increase vasodilation in the venous circulation, which means you're having a reduced venous return. If you have less venous supply in the atria, you're going to have less that fills the ventricles. You're going to have less end-diastolic volume, and during contraction, you'll have a smaller stroke volume. And because you need to pump less blood, you'll have a lower oxygen demand. Remember our calcium channel antagonists. So our calcium channels are involved in binding to troponin C, unwinding the troponin myosin complexes, and facilitating the actin-myosin complexes. So by antagonizing this, we're decreasing vasoconstriction. Beta-1 adrenoreceptor antagonists have sinoatrial activity, stopping noradrenaline in the heart, but they're also involved in the calcium L-type calcium channels, for stronger contraction. So by antagonizing this, you're also weakening the contraction and reducing oxygen supply demand. Nitrates are the most important for this lecture, not because the others aren't important, but because you do them in heart failure in a week's time. This is a slide going through the mechanism of action of nitrates. Let's read this. A result in release of nitric oxide in vascular smooth muscle will vasodilate. Okay, not so. So usually what happens is your body is in a homeostasis between this desire to contract and this desire to relax. The desire to contract is mediated by calcium influx, which is going to bind with your troponin C and eventually phosphorylate your myosin so its head is cocked. It goes with the actin and contraction. This is opposed by nitric oxide, which is secreted by endothelium. Nitric oxide will diffuse across this from this blood vessel endothelium into this area. It's going to eventually have a variety of downstream effects that dephosphorylate myosin and lead to relaxation. When you give glyceryl trinitrate, it donates a nitric oxide structure and acts in this area. And that is facilitating relaxation. Does anyone know what the drug sildenafil is? Sildenafil is. Viagra, really good. So why is that important? Why do you think they put that here? Contraindicated, really good. And do you know why it's contraindicated? Stops relaxation. Yeah, so almost. So the reason why you can't give sildenafil and nitrates is they have the same mechanism of action. So you have too much relaxation, you can go into like very severe hypotension, and you need some contraction to maintain function. So these two can cause syncope, which is fainting, and really low blood pressure. So they're contraindicated, which is quite important. Actually, there's quite a lot of people who use Viagra. Not that I would know. There's no effect on cardiac or skeletal muscle, which is also important, which is why you don't have to worry about like really important functions. You're not relaxing every muscle in the body. We mentioned venous dilation and the preload, falling preload, reduce oxygen consumption. Arterial dilation reduces. So afterload is a concept that, if you remember, I mentioned how your arterioles constrict, you're reducing the amount of blood flow to those areas. By constricting the vessels, when you reduce the diameter of a blood vessel, you're increasing the resistance. And so the pump has a greater amount to pump against. It needs a greater cardiac output to pump against all this resistance from these small diameter vessels. And that can increase cardiac output. So in angina, you'll give nitrovasodilators in order to dilate these arterioles, to reduce the peripheral resistance, to decrease the afterload, and so you have a falling cardiac oxygen consumption to mean that less flow can go through those coronary arteries because they're a bit occluded. Coronary dilation is good for stopping vasospasm, artery spasm. Indications are acute angina attack, chronically prevention of stable angina. Limitations, this is, we mentioned this before, someone asked a really good question about it. When you have a really low blood pressure, your body compensates because it doesn't, the most important thing your heart can do is perfuse all the tissues of your body. And if you have a low blood pressure, that can be compromised. So the way the heart compensates for that and to increases its cardiac output is by having a tachycardia. So this can offset some of the benefits, but is often minor. And another reason why Viagra can be contraindicated is there's more likely to have a reflex tachycardia, which essentially defeats the purpose. Another reason why tachycardia is bad is coronary artery filling occurs during diastole. During systole, the heart contracts and those vessels are occluded, and you want a lower heart rate so those arteries can fill with more blood. Yeah, Andrew, just jump in whenever you have. So some more about nitrates. This is really important, probably will be examined. Sublingual and transdermal. In acute settings, given sublingually, oh no, my computer's going to die. 1 second. Andrew, do you mind just taking over while I charge my computer?
Yeah, so I mean, these are just some examples of nitrates. So you have nitroglycerin and you have isosorbide dinitrate. So yeah, they can be sublingual, they can be transdermal, and they can also be oral. So the sublingual and the oral ones usually are more short acting, and as you can see, like they last a few hours, or I think the first one's less than half an hour, and usually the transdermal ones are just sort of like longer over the day. As you can probably imagine, transdermal, like you'll slowly absorb it across your skin. But yeah, with just if you can remember these names, that'd be nice. But yeah, at the end of the day, it's just memorization. I'll just take a bit of time. I think the adverse effects are sort of self-explanatory. So you can get hypertension, even though because obviously you're dilating your vessels, and we have already discussed why because of this it should not be combined with Viagra. And if your blood pressure is too low, obviously you can faint. Tachycardia, that's your body naturally trying to I guess regulate it. So if it senses the blood pressure dropping, it will try to increase your heart rate. And as we mentioned, it will offset some of the benefit, but it's not major. Headaches, I can't quite remember why you get headaches. It might just be maybe you're not getting enough blood to your head, but I'm not too sure about that one. Flushing is just because you're vasodilating, so you're getting blood to your cheeks and you're just sort of flushing. And something to note is that you can develop some tolerance after continual exposure. Anything you want to add, David?
Not much. Just the headaches are often a symptom of hypotension.
Yeah.
Tolerance is really important. So sometimes people take like a nitrates holiday, so they don't take it for a couple of times so that it can have more effect. And the reason why it's given like this is I think nitrates have like 90% bioavailability, like 90% first pass. So a lot of it is inactivated. Yep, so now we're going to talk about calcium antagonists. They block L-type voltage-operated calcium channels. These are largely in the heart and vasculature. By blocking this, you're blocking contraction, essentially. This is a bit easier to understand because we've learned so much about troponin. You have less calcium influx in, less binding to pronin C, less unwinding the troponin-myosin complex, less actin-myosin chains formed. Reduced calcium entry into vascular and cardiac cells, and it doesn't affect skeletal muscle cells. Therefore, it doesn't really. Therefore, reduction in intracellular calcium, and you have a vasoconstriction because you have less contraction of the coronary arteries, and you also have less contraction of the heart, which means you have less oxygen demand. Calcium channel blockers. So these, unlike the nitrates, so nitrates are very unique in the way that they target venous as well as arterial. Calcium channel blockers don't really target venous. There's not as much smooth muscle in that venous system. So the reduced cardiac contractility, and so ultimately they reduce cardiac contractility and AV conduction. So an important thing to mention is we mentioned that B1 receptors reduce the sinoatrial node, and they also reduce contractility. And the reason is L-type calcium channels are important in signal generation for that electrical conduction circuit, and they're also important in contraction. So by blocking it, you're reducing heart rate and you're reducing contraction. Yeah, so verapamil is greater than diacetyl is greater than nifedipine. We'll show these in a moment, but these are the three most common calcium blockers. Indication are angina, hypertension, tachyarrhythmias, anything when we want to decrease the work of the heart. In angina, it decreases total peripheral resistance and cardiac work, so it's limiting the contraction of those arterioles, decreasing arterial peripheral resistance, And so we can have less demand of the heart and a lower cardiac output, and so less work. It also reduces oxygen demand as a result. Coronary vasodilation can help with variant angina as well, and that's angina due to vessel spasm. So that's really important. Yeah. This is an angiogram just showing you how well it works on relaxing these coronary arterial vessels. So this is a spasm, I believe. Yeah, variant angina. So this is a spasm of the coronary artery, and after calcium channel blocker, you relax that. This is fairly important, so I'll probably get Andrew to talk on this as well, but calcium drugs have different levels of affinity for the heart and for the peripheral vasculature. So something like amlodipine is quite vasoselective. So it's quite prioritizes the vasculature, which means you're going to have a dilation of your arterioles, a reduced blood pressure, but sometimes as a result, you can have a reflex tachycardia, which is minor, but is something to account for. These two drugs are more vasoselective. These ones are more cardiac selective. That's quite assessed. So definitely try to know amlodipine can lead to reflex tachycardia because it is more vasoselective, whereas verapamil has more cardiac effects. Diltiazem is about in the middle, and so it's not as commonly asked. Anything to add, Andrew?
Not really. I guess just to point out that you do get the tachycardia reflex of the heart rate when it's when you use a more vasoselective drug like amlodipine, just obviously because it's not targeting the heart as much. But if you use something like verapamil, you'll get a decrease in your heart rate as well because you're targeting the heart. So that's why you see the reflex in more vasoselective types, but not in the cardiac ones. But yeah, so just to know that, yeah, just try to remember which one's vasoselective, which one isn't vasoselective.
Yeah. Which is, just remember the suffixes for the dipene.
Yeah, the dipene.
That way you don't have to learn two drugs. Verapamil, you might just have to learn. I struggled with this, I must say, learning these names. So hopefully, because we keep saying them over and over again, they're getting stuck in your mind. Some adverse effects are what you would expect if you are limiting the amount of contraction. You don't want your heart to stop contracting completely, so you can have cardiac depression. If you're limiting the heart rate, you don't want complete bradycardia, which is why if you have heart failure, which is when the heart is struggling to have sufficient oxygen supply and also to beat it, it's contraindicated in heart failure. You don't want to give a calcium channel antagonist in heart failure because you want to support the heart as much as possible. So you'll give things like inotropes, which support the contractibility of the heart. You would not give inotropes in angina because the whole point is we're trying to put less strain on the heart. So just remember, calcium channel antagonists are contraindicated in heart failure. You have a lecture on heart failure next week, so that will be re-emphasized. All these vasodilator hypertension effects, headache, dizziness, edema, flushing. Flushing is because the vessels in your face are dilating. Some GI disturbances. Yeah, again, do not use calcium channel antagonists in heart failure. If your heart is failing, you don't need to help it. And yeah, verapamil or dielstaman should not be used when combined with a beta blocker. Yeah, that's another contraindication. So that's because your beta blocker is going to reduce your heart rate, and you don't want this tachycardia reflex. And when you're giving these drugs, you're more susceptible to that as well because you have no compensatory mechanism for that decreased blood pressure, and you want to maintain cardiac output.
Yeah, so it's basically just like doubling your because verapamil and diltiazem will already like lower your heart rate, give you some cardiac depression, and if you give a beta blocker as well, that just might be too much. You know, you don't want to kill, like, you don't want the heart to stop beating completely, basically.
Yeah, same thoughts with your nitrates and your sildenafil Viagra. Good in moderation, but in too much, you're in trouble. Beta blockers. Beta 1 are predominantly in the heart. Where are beta 2 predominantly? chuck in the chat. Good job. 2 lungs, 1 heart. Beta 1 heart, beta 2 the heart. When noradrenaline binds to beta 1 receptors, it increases the heart rate, primarily due to that relationship to that L-type calcium channel. Beta blockers block this. So you have your sympathetics. This is your presynaptic ganglion, postsynaptic. Yeah, that's not too important. All you need to know is beta blockers block adrenaline acting on the heart and that heart rate. So beta blockers decrease sympathetic drive to the heart, so they decrease your cardiac output. And the reason they do that is because cardiac output equals heart rate times stroke volume. So if they're decreasing heart rate, they're going to decrease your cardiac output. Renin release, don't worry. Example, do you think don't worry about renin release? I definitely don't think renin release.
Probably not right now. I don't. When do you even do renal? I can't even remember. Did we do renal this year?
Yeah, we did.
I can't remember anything anymore.
Yeah, no, I don't think worry about that too much. Beta blockers, you can have selective and non-selective beta blockers. So propranolol is non-selective beta 1 and beta 2 antagonist. All of these are contraindicated in what condition?
Have they done respia?
They've learned this. Asthma.
Okay, right.
Very good, because when we did the receptors, we told them that. So very good. What about COPD? Good question. What about COPD? I don't know. I don't think COPD has much of a sympathetic component. But I don't know. That's a great question. Definitely don't need to know that in first year. I'll get someone to search that out. But yeah, important to know that propranolol and metoprolol are both beta blockers. But however, even though this is beta 1 selective, you still don't use it in asthma. That will be on your exam. Don't use that in asthma, even if it's beta 1 selective. So you use beta blockers in everything: in angina, arrhythmias, hypertension, post-AMI, and for clinically stable heart failure. They decrease cardiac oxygen demand by decreasing that heart rate, and they allow greater flow to your coronary arteries and greater perfusion because they fill during diastole. So if you decrease that heart rate, you're going to increase their perfusion. How do you know what COPD is in year 1?
So
why would you give beta blockers for heart failure? 1 second. Why? It was in our rural health topic. Oh, nice. Yeah, so in heart failure, what you're doing is there's a type of heart failure where the heart is beating too much. So you're having like hyperplasia of the muscles, lots of muscles in the heart, so much muscles building up to the point that your diastole is actually letting it to fill less because it's working so hard. So you do want to some extent, reduce that, but you don't want to use calcium channel blockers because then you're going to like really damage the heart. These just allow for greater perfusion of the vessels, and they kind of decrease cardiac oxygen demand. So they're a bit lighter than like calcium antagonists, which are just making your heart not beat as much, which is quite dangerous. I mean, it could work, but it's just dangerous is the point. So it's all about finding a balance between the two. Does that make sense? Wouldn't that make it beat less forcefully? No, it wouldn't beat less forcefully. It would just decrease the heart rate, essentially. It would have a little bit of effect on beat less forcefully, but it's almost entirely on the heart rate, predominantly. Beta blockers adverse effects. So we've got our bronchoconstriction in our asthma, which we don't want to use. I'll find out if it's COPD because I probably need to know that for my exams. Cardiovascular, you're going to decrease heart contractility, but you're mostly going to have bradycardia, which is a low blood pressure, an AV block, which is mean there's a greater time for atrial filling, exercise intolerance. Do you know what these words mean? What claudication means? Yeah, you all know what claudication means. Can someone write in the chat what it means as briefly as they can? Pain and cough, yeah, good job. That's because you have, yeah, looks like you know. Impotence is a very big adverse effect of beta blockers, not that I would know. And beware of sudden withdrawal, because you can have like a very high compensatory mechanism, your body gets used to it. These aren't that important. Beta blockers aren't useful if there is a spasm, because that's a muscular thing. And so your increase in filling isn't going to do much. You're going to want to use nitrates and calcium. No worries. So almost done. This is HEP. I don't know who did this. This lecture was a bit long and all over the place, so I haven't summarized all the content. I've only included things I believe are high yield and cross-reference for year one exams. Oh God, okay, super summary. So medical error is a significant problem. Apparently it's the third cause of death in the US in 2013. So yeah, there's also the greatest chance of blood fusion failure. So if you give someone the wrong blood and they have a hemolytic event, is most commonly because they get the names mixed up, some clerical error like that. So this is essentially saying medical error can be reduced through mindfulness. So no, stop smiling. So mindfulness can help with motivation, with stress, with performance, and with performance as well. This is all true. We need a little bit of stress to work hard. So the frontal lobe is involved, which is responsible for attention, working, memory, self-awareness, emotional regulation, impulse control. Yeah, so what would I remember from this? Remember that medical error is a significant problem. Mindfulness is the answer to everything. And that this keyword of inattentional blindness. So for example, do you remember that video when they play that people are passing the ball to each other and a gorilla walks on stage, but because you're trying to count the amount of things, you're not paying attention? It means when you've really got tunnel vision looking for something particular, you miss other things. It's also known as confirmation bias. So you're looking for things, you only see things that you're already looking for. That's quite important in attentional blindness. This is saying that relaxation without awareness is like, I'm just going to lie in bed all day, high performance, a bit of stress, very high stress is poor performance, can't focus. There is a stage where you can have high performance and not be stressed. We did that in our shoot, but I don't think that's in this performance curve. So the radiologists were looking for lung nodules and they missed all of this because they were focused on their attention. I mean, it's their job, so I don't know, but whatever. They were looking for lung nodules, so they missed the wider picture. So you have to make sure, just because you're not paying attention, you don't see things, you should always pay attention. I guess that's more to say that when you don't do attention, you don't do what your job is required, rather than say you miss things that isn't required of your job. Summary 2, working memory is your short-term memory, and stress. Okay, this is really important. Stress is an increase in anticipation of a bad event. Taking notes is better than typing. Who cares? Reading from paper better than screens. Who cares? Attention deficit trait is when you're trying to deal with too much input, so there's an inability to focus, and can be helped by having a clear environment for setting time of the day for nothing. Let's do that again. Attention deficit trait is when you're trying to deal with too much input, so it's like a sensory overload, and you kind of need to just clean your desk, go for a walk. It's a bit hypocritical, but you need to clean your desk, go for a walk, and just clear your mind. That's what they mean by clearing mind. So if you have too much going on, too much input, you can't concentrate. Multitasking doesn't exist, will be on your exam. So simple multitasking is each task given the same priority, e.g. staring past while talking to spouse. Apparently staring past is as important as talking to your spouse, but there's different types of multitasking. Some, like when you're driving and you're on the phone, that's really complex multitasking. You really can't do much. When you're doing that, it's quite dangerous. Simply multitasking, you can kind of get away with, like staring apart while talking. But really, there's no such thing as multitasking. You're just switching between activities really fast, and there is a lag. So you also don't retain the information. There's no difference between boys and girls for multitasking. I think that's quite commonly asked. And when you multitask, your performance is worse. Silence is better for studying than music, except I think they said that classical music was all right.